So welcome back. We're going to go ahead and finish off the answer to that question that we had just before we broke.
So if EMS providers haven't realized that doctors can be an ornery lot to try to change, but you know, in the last 5 or 6 years, there have been many things that have come in, often from EMS, that need a programmed response in the hospital. We have the STEMI alerts, we have the stroke alerts, we have the trauma activations, and I feel confident in the next few years every hospital will have some sort of sepsis alert if they have an emergency department, and even if they don't, they're going to have it for their inpatients. And when, you know, one of the problems is the presentation of SIRS can be very, very variable. So lactate can be one of those quantitative pieces of data that, you know, if the person on the ER end is you know, not really sure if they should set off the alert, it'll give them something with more confidence. They'll be able to do it. Just one last thing to say is that it's not just the fluid that these sorts of activations help. They get first in line for the CAT scanner, unless there's a trauma patient, of course. And you know, they get first in line for labs. They get their labs quickly. They get moved through the system, and I think all of those things benefit the patients.
Yeah, I think what Jeff is saying is absolutely true, that we are going to have sepsis alert teams in the future. The one thing that I think is not true at this point is that physicians and personnel respond to the lactate as we could. Frequently, fluids are still being hung without pressure bags, antibiotics don't get given fast enough, and the wheels are not greased in the way that usually happens when somebody hits the door with a STEMI and they need to get to the cath lab. There is no such thing as a door to antibiotics time for sepsis, although that is being looked at and measured. The thing is that folks have just not really taken sepsis as seriously as MIs or strokes, but they should, because the mortality is exactly the same, sometimes worse. The issue with regards to sepsis alerts in the hospital is something that can be addressed electronically. Martha Jefferson is going to start having a crawler in the system that basically looks through vital signs to pick up SIRS. Once the additional data are brought in, whether there's organ dysfunction, a sepsis alert is going to be triggered. Now, who is going to get that sepsis alert is going to be another question. The primary nurse is one of the first people who's going to get it, but then the doc has to go in there and see whether it is truly sepsis, severe sepsis, septic shock, and whether this patient needs to be treated for that. Now, all of this comes with expense, but it is totally useless if the physician and the nursing staff are not on board with the importance of this. And that means starting with a lactate. I mean, that's really where everything seems to be originating from at this point. And so I think it'll be difficult for you as EMS providers to hand off a patient and being all excited about, okay, I've got a sepsis patient, and you'll get a lukewarm response in the ER or at the hospital or somewhere. So there has to be more education, there has to be more enthusiasm for folks to recognize that this is as important as an MI or a stroke.
And I hear that all the time. When we were preparing to do this today, I spoke to several people, and what they said to me was, we can do this, we can become more acquainted with sepsis, we can be better educated, but frankly, when we get to the hospital, nothing is going to be done with it anyway. And I think as an EMS group, we tend to be people who are action-oriented and result-oriented. So when you get to a hospital with, as you described, a sort of a lukewarm response when you get there, it tends to kill anyway that interest. And if we're trying to elevate people's understanding and knowledge, what do you think practically could be done to get that response in the hospitals? Education is one of the things. Any other, from all of you, any suggestions of how we could put a system in place where that information is given and then some action is done and seen to be done when the patient presents to the emergency room?
Well,
I mean, this is a pretty similar scenario as we saw before with stroke alerts and STEMI alerts and everything else. When it first came out, it was like, how can we do this? How can we staff a cath lab 24 hours? How can we have a trauma team here 24 hours? But once studies came out and proved that it actually made a difference, it made a difference. And certainly, from an EMS standpoint, when a patient comes in with a stroke alert and the patient's rolling off the CT scan before they even clear the room sometimes, it certainly gives visual and tactile feedback to the EMS providers that they've made a difference by identifying the patient and calling it in. Obviously, if the hospital is going to give a lukewarm response to stuff like that, the EMS providers often have other hospitals they can take patients to. Their goal is to get the patient to the best possible care possible. In Charlottesville, there's 2 hospitals. In other places, there's 20 or 30 hospitals that patients can go to. So it can make a difference all the way around from every level of care. But from the hospital standpoint, it's just like anything else. We educate people on what a STEMI mean. We got a team together, and everyone bought into it. We have to do the same thing with sepsis.
Dr. Schultz?
And we have done this for some time. I've been knocking my head against the wall for about 7 years now. And finally, we're sort of coming to a point where we're realizing what things work and what don't. And there is basically going to be a huge effort of education of physicians again and nurses in a manner that should increase the awareness with regards to sepsis and the treatment of sepsis, the mortality issues, and the fact that we have to get lactate sooner, and that really we just need to treat it like an MI or a stroke with the same respect and speed.
And in the trauma patient?
Well, I think that one of the deficits in getting sepsis made into the same kind of program response is all the other ones have kind of had a champion. STEMI, the cardiologists in most times take the lead. Stroke neurologists take the lead. Sepsis crosses a lot of boundaries, so obviously it makes sense for Alice to do it in his hospital. In our hospital, there's been kind of a diffuse leadership of it. EM, MICU, some lesser surgery. So I think having a leader is what makes it happen. I think believing that a programmed response is the right thing to do, which it is in this situation, works. And what I always say is it ends up being easier for everybody. If you have a program response like this, if somebody rolls in, they're going to get their fluids, they're going to get intubated if they need to, they're going to get their cultures drawn, their chest x-ray, maybe a Foley, and quick exam, categorize where you think the sepsis is coming from, get those focus studies, give antibiotics. That's easier. It's easier than having to go through 3 different levels of people looking at them, and they're going to do better. So it's less cost in the long run. So I think it's going to happen. It's already happening. Martha Jeff may be ahead of us in where we are, but we're trying to make it work. And I think it'll be in place in I would hope most hospitals very soon, if it's not already in place.
I think one of the things maybe that is worth mentioning, and just a comment on the side here, it's not like we've invented or discovered a parallel universe here. People have known about this. It's been published and documented for a very long time, 10, 12 years. This is no surprise, folks. And I think you hit it on the head to some degree, no champion. Well, let's suggest this, that 80% of tax dollars spent on healthcare in the last 6 months of life. That in itself maybe is a champion for people to do this. This sepsis is a very expensive disease. So we've examined a lot of things to do with sepsis in trauma in medical patients and lactic acidosis in general. And the question wrapping up I'd like to ask is, if you gentlemen had something that you could change, both in your practice or in the facility that you work, that would facilitate all the things we've talked about, take your pick. What would it be, each one of you?
Well, we've been talking about it the whole time. If rescue squads were doing lactate, it would make my job as an ER physician much easier. I already know the patient's sick. I already know what to do before the patient's getting there. I know that if it's a lactate above 4, I'm calling Alex 5 minutes into the patient's arrival so he can get admitted to the ICU, and the patient's getting the appropriate treatment. And if we had it as a sepsis alert, then all that would happen more automatically. And just like the care of patients in trauma alerts and stroke alerts and STEMIs, the care is better for all levels of patients within those categories. The overall care of the patient will be improved.
Okay.
Yeah, it's similar to what Jeff is saying. Jeff on one side, Jeff on the other side. Heighten the index of suspicion is really what I'm after. I don't care whether it comes from EMS, from nursing, or physicians. And the one thing that can allow us to increase the index of suspicion for sepsis is to get the lactate. I mean, we've practically beaten this one into the ground, but it's better than a vital sign at this point to allow us to ascertain what the mortality might be for this patient and what intensity of service we should be offering this patient. And I don't think we're any more ahead of this at Martha compared to UVA. It's all about the index of suspicion, the education of physicians, nurses, allied health professionals that will make this happen in a way that less patients will die.
Well, one thing we try to say that is one of the most difficult things is making that sick, not sick determination when either you walk into a room or you see a trauma patient or you see a sick patient. This helps you make the sick, not sick determination. And we've primarily talked about raising our suspicion, but it also helps in triage. That, if Jeff sees someone who's got a lactate of 0.5, but you may have a bad cold, and then a similar patient with a lactate of 6, it allows you to triage one in one direction and triage another, which, just makes everything more efficient and better. We check lactate on virtually every injured patient we interact with. It's one of the first things that we communicate to each other. Getting it 10 minutes earlier, or in long transport times, getting it 40 minutes earlier, could do nothing but help.
Okay, so we wrap up now. We've looked at several things. It seems to be clear the consensus is that lactate testing in EMS has a utility. It'll help these patients. There's certainly some challenges as to getting the system in place and having it accepted. But clinically speaking, a high index of suspicion, treat these people with fluids. Don't be scared to give the fluid over taking care of their airway. And just generally speaking, have in your mind a person who doesn't necessarily look clinically sick, that traditional presentation that we've all been taught, maybe hypotensive. One of the studies I happened to read said they would quite happily, in the correct scenario, replace a lactate number with hypotension and give it the same value as we had traditionally been told to give hypotension. This video and several others are available on our website, which is facebook.com/Orange Fire and EMS. And I also encourage you to have a look at Dr. Young's website, and it's clinicalbraintraining.com, and also fire/EMSbraintraining.com. Like I say, this video and others are all available there. Hope you've enjoyed it. I hope you've got something from it and maybe learned something new. Thank you all very much.